We have our progress.
Good morning. Thank you very much for the kind introduction. It's really an honor and a distinct pleasure for me to be here in Korea, in particularly at this Congress Summit. I'd like to start by thanking Dr. Lim, Dr. Lee, Dr. Tang for the kind invitation, Dr. Yu for being very close to me during the visit and before the visit, and to your esteemed selves for moderating this session. So I'm asked to talk about the preparedness and what did we learn from our experience with the Renal Disaster Preparedness Working Group of the ISN. So this is my slide, and this is a QR code for my contact number, but it is available. And these are my disclosures. And I want to thank ISN for entrusting me with this role, and they are endorsing this session. And but what I present, although it presents some of the ISN work, is mine in terms of views and responsibility. So this is the plan of my presentation. I'll go through some topics in some detail, and others not in as much, but happy to share them upon request. So we'll start to talk first about the vulnerability of kidney patients and what kind of disasters are we facing these days. National and regional response task forces, what do we know, and give some examples, but really focus on the global responses, including the ISN Renal Disaster Preparedness Working Group, and the new things that are happening on WHO front, and as joined with global societies with the ASN and ISN. And then what do we propose as an action plan, and this is subject to review still. So this was shared with me from a meeting we had in Copenhagen with Dr. Valerie Lutz. It's about disasters and the vulnerability of the kidney. The term disaster is probably being changed to another term, but this is subject for another lecture in the next few months. But there are natural ones, as we see here, from earthquakes, storms. There are infections, as we saw with COVID, before it was SARS in this part of the world. There are things that are man-made or human conflicts, especially armed conflicts and related issues, mass displacement and refugee crisis, and we added financial instability and other things that are also becoming an issue. They all affect the kidney patient because of, for this audience, don't need to go of why kidney patients, especially on dialysis or having received an allograft, are so vulnerable to disruptions in care. Are disasters common? Well, this is from a paper from Robert Lemaire from 2020, and it talks about 2018, and this is 11,000 deaths among various disasters, and this part of the world has a significant number of events. The Middle East had two, it's not shown here, distinctly from all over Asia. But already in 23-24, we have 10 to 11 folds the number of deaths between the earthquakes, between the war going on in the Middle East and the Ukraine war. So we already very quickly can exceed the number of deaths in an event, and that means there will be a lot of pressure on the system for kidney patients as a result. Although they represent very small number percentage-wise of the population affected in a disaster, their needs are immense, immediate, and life-threatening. And this is why we have this session. And we thank the KSN and APSN for including this on the program. Start with economic collapses. So we have seen a number of them, and each one of those little articles addressed kidney patients with economic collapse in Sri Lanka, in Lebanon, in Venezuela, and many other places. So they're vulnerable to governmental disruptions in funding because dialysis primarily is funded by government all over the world. I got into this work after dealing with a refugee crisis in Lebanon from Syria, where we received in a tiny country of Lebanon 2 million refugees to a population of 4 million. But then in 2020, in the evening, we had this big explosion, and this would get me going with this work even more. Here, I want to thank the ISN immediate past chair of the working group, Dr. Adrian Liu from Singapore, because Adrian and Dr. Maiza Kazanjolo from Istanbul called me within hours And this is exactly what the ISN working group is about, is to reach out to each other worldwide and try to see how can we help, how can we understand what's going on, and this will be the emphasis of what the working group tries to do. So this was a big explosion. The impact was immediately high, but then with time it dwindled. But then we started seeing more stuff. So now we have armed conflicts that are seriously disrupting care. This is 2021, and you can probably start adding some additional pink dot and pink areas to this map that Mehmet Sever, one of the leaders as well, with Dr. Van Holder in this area of work with disaster relief. And currently the focus, of course, is on Ukraine and on Gaza. So these are in very high level of activity. Sudan is becoming a chronic issue. We'll talk about that a little bit. But this is how it looks like. So this is a checkpoint in Syria during the height of the civil war, where dialysis supplies have to be transported across checkpoints with multiple involvement of the Red Cross, other agents, MSF, to get some dialysis solutions. And you can see how tedious that could be and how dangerous it could be. That if you can cross. As we see today in Gaza, it takes a lot more effort to cross borders and to deliver supplies. Ukraine, there was quite a significant impact because of the high number of patients and about 13 million displaced people. This put a lot of pressure on the system in Europe, but this was addressed with a lot of effort, especially by the European Renal Association, and this is how we started accumulating collective experience how to deal with these crises. My colleagues, Serhan Tibrula, who's a vice chair for this group, for the working group, and Valerie, that I mentioned her name, put together a nice paper summarizing the 3 major conflicts in the last year and a half, or 2 years, from Ukraine to Sudan to Israel, Hamas, Gaza at present. And you can see the numbers are staggering, but the issues are different. In Ukraine, there was high impact on terms of displacement, but there were resources. In Sudan, that we dealt extensively with it as ISN working group, with many weekly conferences with global presence to try to get supplies mostly, and that did not result in major difference because you need major organizations to help you, and we'll talk about that. In the Israel-Hamas-Gaza ongoing crisis, the different issues here are that there are supplies at the borders in Rafah, in Egypt, that we cannot get in that easily, but also within the territory, within Gaza, there's no electricity, no water, but this is being addressed gradually, but clearly the needs are not met, and like in Sudan, a number of patients on dialysis has unfortunately lost their lives because of lack of therapy. So we have an immediate task at our hands of how to address these needs. Switching from armed conflicts to earthquake, the latest one was in February 2023 in the Turkey-Syria border, which is already a difficult area because the part of Syria is already divided into 2 because of civil war there. And I took this picture from Serhan, and here are how earthquakes or the disasters in general affect dialysis patients, and I listed here things that we think about commonly: access to centers, access of staff to centers, well-being of staff, and then for PD it's a bit different. We have recently analyzed the disruption in PD supplies to Lebanon because of the Red Sea crisis at Yemen, and it is a global chain that you don't imagine how complicated it is until one of your bags is not there. And then also we should not forget transplantations and access to immunosuppressive medications. In Turkey, there were 55,000 deaths with this earthquake, but they have a high level of preparedness from 20 years or 25 years ago, before with the Marmara earthquake, when Mehmet Sever and Ray Van Holder really laid the foundation of how to respond. In Syria, it was much more challenging. We don't know who to talk to. We don't know who can get supplies to which side of the 2 parts of Syria that were affected, and was walking on eggs to try to do some of this work. And so that obviously much more challenges. The numbers were less here, so the impact was a bit less acute. We should not forget our personnel, from healthcare workers, from our terrific nurses, technicians in the dialysis unit, the drivers that bring supplies, to the doctors. All of this is under pressure when there is a natural disaster. And it is something that we should keep in mind when we look at the overall picture. So what happens to standard of care? One word about standard of care, it declines. It declines acutely. And this has been well documented in a number of settings. And I would mention here a paper about the COVID experience. That's the only word I'll say about COVID. Also, it was a global disaster, of course, for everyone that affected dialysis patients. There is evidence that the low and low middle income countries disproportionately suffer from lack of care or decrease in the standard of care during disasters very quickly. So that's why these are very vulnerable populations and very vulnerable areas that we need to consider as we think through this of how we try to advise or respond. So moving next to the next point, which is the national and regional response task forces, and I start with Dr. Yu's paper. That is a great example of one for a country like Korea. And here is, I'm not going to go through this, but a wonderful detailed plan of how you can try at a national level, disseminate it to the local level, of a plan that you will work on to advance. I know now there is a committee of the Korean Society of Nephrology for disaster, and that's the natural progression, and this is terrific. Then we have, on a wider region, this is a paper from Adrian and his colleagues about Asia Pacific in general. It has very valuable information at even unit specific level. So there is information out there that is region specific, country specific, but also what we need now globally is off the shelf guidance book, that what happens if I have this? So you go and grab it. And this is what we're working with on the ISN side, and probably with the other societies, to collect together valuable information that's validated and then updated of what to do. We will hear about diet in the next talk, so I put this in as a plug-in for my colleague that we speak. But this is put by Ray Van Holder because we need to educate patients. But it's not about diet. We need to know what to do if the disaster happens during the session in the unit, if the earthquake hits. What to do with the access. What do you tell the patients? There are a lot of educational material needs to be out there to give to patients and to us of what to do during or after a disaster, but also pre as well. What are the emergency stocks? Does task forces like the one you created help? The one our Turkish colleague helped? I get this data from Serhan, and basically in the Marmara earthquake, there were about 600 crush injuries, high mortality rate. The response was by the predecessor of the ISN Renal Disaster Working Group. It was the Renal Disaster Relief Task Force. It was an interventional ISN task force that would go there in person and provide care. This has morphed into the Renal Disaster Preparedness Working Group, which is more about preparedness, but it's also being revisited. But this is the older model. The new model is where they develop their own. So the Turkish Society of Nephrology has a very advanced response task force. That could show in the number of patients that had crush injuries, the number of children. All they needed from the working group is some pediatric catheters this time, despite the humongous impact and the number of death and the destruction. So, and the mortality went down. So this is something that really make a difference. Protocols and related steps of who to talk, where to go, what is your emergency plan, all of this helps. So we'll probably see more of this in terms of networks at national level that will decrease the mortality and improve the outcomes. So what are the global responses? So back to that same paper that Serhan and Valerie put together, we discovered what you can do and the limits of what you can do. In Ukraine, there was much more success because there were many more resources. It was in Europe, and it was geographically possible. In Sudan, we barely get supplies from one company. Then we started seeing how difficult it is to get supplies, to get donations, and when the needs are in the millions or tens of millions of dollars because it's getting protracted and it's going on with a lot of destruction, then you realize that all you can do is basically advocate, push the issue, make sure you make the issue known globally, but you need, on the other hand, listening ears. And this, every single time, you need to repeat the same story to the donors, to the relief organizations. Ukraine have sensitized the ears. The time Sudan came, our job was easier to some degree because we were talking to people who were involved in the Ukraine crisis, and then these relief organizations were more nimble at responding, but they can do only so much. We as doctors, we as ISN, we put a relief, the Direct Relief is an organization for donations, together with other organizations. What did we collect? We collected globally $6,600. This does not, of course, answer any need. This is very little. So you cannot depend on this kind of fundraising to make a difference in a crisis like this. Those $6,000 turned out to be for that day that they needed a truck driver to move supplies from the port in Sudan to the capital Khartoum, where nobody would go because the road is so dangerous. $6,000 made a difference to make a truck go with supplies for many weeks. But that was one time. So that tells you that the global response needs to be of a different kind. And now with Gaza, you could see where the impasse is much more difficult to surmount. So who are we and the working group? And we are listed here. And the distribution of members is geographic. And this is important because if there is an event in the world, one of us will be awake and will be able to text the group and say, this is what's happening. And but it's not sufficient. So we invite people to express interest in the working group, and then hopefully we will be able to have more representation by region and by experience, because we need that. What did our predecessor in the task force do? They responded to a lot of stuff, a lot of crises, I mean. What are we doing? There are now more organizations involved. This is from Dr. Van Holder, and there are probably additional events that we can add. There's also the floods in the US and the hurricanes, and so we are moving to a different way. This is what the ISN have been doing, this group, where sometimes we have, in the last 2-3 years, some major interventions like with Sudan, or minor interventions, or just a phone call or an email to the head of the society after a major earthquake, let's say, and then any help we can offer. And this is something that we just did in Brazil, where our mostly cognitive support, material support, by documents and by having Zoom calls. So it depends what you do. The Sudan was weeks of meeting. Gaza is led by ERA, but KSN joining in for many meetings. So we put this paper, very short letter to Lancet. It took months to publish it despite a big push, because the need was months ago. By the time this comes out, the need has already been at its peak. So this is clearly a desperate call for help. We need this to be much more efficient. That's why we were very excited when the WHO at the high-level technical meeting on non-communicable diseases in Copenhagen invited the ISN to have a side event on dialysis. This is a big deal, because now we are on the map. It is among the priorities. They realize that dialysis and dialysis patients, kidney patients, are a big group in the NCDs that requires a lot of effort and attention. So we did that with the support of ISN, and Dr. Sharu Malik is here. She's the CEO of ISN. Sharu doesn't like me to point her out, but I will, because she has been very, very supportive of this effort. These are the group that we went there. We worked together on putting a presentation, and we have video testimonies from different places around the world. So now it has moved, where the three societies, ISN, ASN, and ERA, clearly recognize they need to work together. And then in December, and they met in Washington, and there was the end of the era of statements. Because if you go and read the news, there was a lot of issues with statements, especially with the Gaza war. So statements are not the way these societies will work. They're going to go forward with action plans. What these action plans look like? Basically, the first action plan was to create a task force, and I'm at liberty to share this now, where there will be basically a task force between the three societies to work together in response to crisis and to work together in preparedness for crisis. So this is ongoing work. It just started maybe 2 months ago, and we have an agenda item of things to do, and hopefully we will be unified in what we present. We'll be presenting material, we'll be present of educational meetings and stuff like that. So last part is what to do together. So this is a whole list of actions, call to actions, and I'll conclude there. So dialysis is increasingly more available, which means there is more vulnerability. So that's something to keep in mind. We know that there's a big growth in dialysis needs and provision in Korea, because we know that from the call I had with my colleagues. So this puts more people at risk. And that's why we need to strengthen registries and communications during peacetime or quiet time. And dialysis represent a worst case scenario and the time of the essence scenario, which means it is bad, and it's bad immediately, and you need help immediately. It's not like you can wait for 2 weeks or 3 weeks for the truck to come. And this is where we need to make sure we communicate this very clearly to all our partners and organizations. We need to engage those partners, those stakeholders, and we have to have a robust and cooperative, effective collaboration to rely upon immediately when something happens. I don't want to go be fiddling around who to call. After the Beirut explosion, it was COVID time. I happened to be in the office for the month of August instead of taking a usual leave. All I did is discover who to call. And from one to one, then you start learning that, in fact, you need to have a list of people to call in your country, in your region, who are the key people, and try to update them. And this is not easy, but it's very important. Anticipate major barriers. Anticipate that people will say no, this is not our priority, but we need to have some strong planning that happen, like we saw in the Turkish model. We need money. Without financing, this doesn't go anywhere. And that's why you see with ERA response to Ukraine, there was much more success, much less death. In Sudan, it was late, the money to come, WHO intervened, but it was not immediate. So there is need to have money. But also sometimes money doesn't help, or alone doesn't help. You need money. In Gaza, there were supplies, there's a lot of support, but just you cannot get in because of the geopolitical situation and the ongoing war. And we need more transparency and cooperation. Action 2 is prolonged disasters are becoming chronic. Syria, 10 years, 12 years. Decreasing in intensity. Sudan, still going. And I don't even know where we are. We need data. Data is another big thing in these disasters, to collect data from the ground, and we don't have a mechanism to collect data. This is one of the priorities of the Three Societies Task Force. What to call these disasters, new names for them. The WHO introduced the term humanitarian settings. Data is a big item. How to get data from the ground, who to share the data with, what are the regulations that allow you to share data or not share data. So this will be very important. And then the burden of kidney disease is rising globally, which means preventing people from getting to dialysis is important, so we have less people impacted by a disaster. And these are big items for all societies, of course. And then we need to recognize the vulnerability of our patients living with kidney disease, which markedly increases and very quickly, as we mentioned from the beginning, in disasters. And we should recognize that. So in summary, I have 2 slides. One are these important salient points from video testimonials we had at the WHO meeting in Copenhagen, where we had people who are nurse in Turkey in the earthquake, doctor from Ukraine, a doctor in Sudan who happened to just graduate but lost her mother because she could not provide her with dialysis because of the lack of supplies, and a patient from Sudan who relocated to Egypt and describing the struggle of making this 1,000-kilometer journey, which sounded like very tough. So powerless of patients and families, they need help. Our dialysis patients need help. The critical importance of knowing that you have well-trained staff and prepared to deal with this. We, of course, salute all our colleagues, doctors, nurses, healthcare workers that have the resilience to kind of stay within the area of disaster and work under extreme adversity. But at the end, we need clearly, our testimonials highlighted the importance of political collaboration and high-level recognition of the issues. So in summary, disasters pose serious and rising challenges to renal care at the global level. Conflicts, earthquakes, and related issues are major disruptions and they will affect any type of dialysis. Preparedness networking are key element of any plan, and we saw that in Dr. Yu's paper. Local, national, regional plans, building them up are important. It goes down all the way to the level of the unit, ultimately. But we really need to work together as major organizations around the world. And I put WHO last but not least, by no means, because you discovered you need organizations like the WHO or in a region, maybe something equivalent that will respond and help you with that. So thank you very much. With that, I invite you to Dubai, to the International Society for Peritoneal Dialysis meeting. Allow me to have this plug in here, and thank you very much.
Thank you. Any questions for the floor? Professor Ali, if there is shortage of the equipment of hemodialysis for hemodialysis in disaster, should be reduced. The hemodialysis station number is reduced.
Yeah, thank you. So thank you for the question. So how to, in a way, provide dialysis under minimum standards? Like do you increase the number of sessions or number of hours? Is this a question?
Yeah.
So, this turned out to be a very important issue when we dealt with the refugee crisis, because donor organizations that came to us and they said, like, in this European country, we can only give money if you give 4 hours of dialysis 3 times a week, because that's the standard of that country, and we don't want to be seen as giving less adequate dialysis. But then there was no minimum standard. So what is a minimum standard that's acceptable in a crisis? It defines itself, but we have not done the academic work to see what is a minimum standard that's safe. So we see now in Gaza, 2 sessions, 2 hours per week. We saw recently in Lebanon, we have an abstract for ISPD, where the disruption in PD supplies coming through the Red Sea from the plant in Saudi Arabia, where we have seen cut in number of bags, number of hours, number of days you're doing PD. So it kind of imposes itself, and you get to the point where at least taking care of that potassium and that fluid not to die. But this is not on the long term. But we don't have a global minimal standard for disaster. That's something needs to be developed.
Yeah.
Thank you.
And Dr. Yu?
Thank you for your nice lecture. And
Thank you.
as you mentioned, our paper, this is first experience in South Korea earthquake, 2016. And I work with Professor Cha in that area. I want to ask that how we increase the disaster awareness in our population in South Korea situation. I want to ask about that.
Thank you. So that's for the kidney population?
Not only kidney population, but
in general?
in general, yes.
Yeah, I mean, I'm not an expert on this kind of public health aspect of how you raise awareness for disaster, but at least from the kidney point of view, it really starts at the unit level or the clinic level, that we need to have maybe periodic sessions during quiet time of, if this happens, what do we do? These are the diets, have you reviewed the diet recently, and things like that, and to at least raise the awareness of the people that we care about the most during a disaster, who are on dialysis, PD or hemo, or have the transplant medications, what their emergency supply medication look like at home, and stuff like that. At a much bigger level, I think I need to leave it to my colleague in emergency medicine and public health.
Starts from the unit level.
Yeah. Thank you.
Yeah, last question.
Hi, Adrian Liu from Singapore. I was the past chair of the disaster preparedness, and Ali, fantastic talk. Just 2 comments. I think one is the disaster preparedness plan that is developed by the country is very important for the kidney disaster preparedness plan to be in-depth discussed with the overall disaster preparedness plan of the country. I will tell you that in a disaster, the kidney preparedness is the least priority, because they will be more concerned with food and water, with other emergency and dialysis patients usually take a priority. And as part of the disaster preparedness working group, that's something that we have been trying to push forward, that awareness of kidney disaster is going to be significant. The other thing with regards to the hemodialysis comments that I have is that let's not forget that you're not dealing with your chronic dialysis patients, but you are going to be dealing with a lot of crush injury, with acute kidney injury, where that's going to take up, in fact, a priority in terms of dialysis requirements for all those patients with AKI, and that invariably you're going to have a reduction in the number of sessions or in the number of hours of patients requiring your chronic dialysis. The other thing that is always poorly emphasized is the role of peritoneal dialysis in a disaster situation. And there are studies that has consistently shown that patients on peritoneal dialysis have a much higher chance of survival in the disaster. The other thing that I think part of the Saving Young Lives and ourselves have been trying to work at is the development of making peritoneal dialysis fluid during a disaster. And that's not difficult. It's been published in our review paper that you could just use 5% dextrose solution, calcium chloride, sodium bicarbonate, cook up a peritoneal dialysate, and that actually can be extremely life-saving. But that is not something intuitive to the normal physician on the road. And so as part of the disaster plan, training is required, and you will need to kind of practice the plan on a regular basis. So just a few comments I have. Fantastic talk.
Thank you very much.
Yeah.
This is all very, very important points. Each one by itself is a session or a chapter, but absolutely. PD starting from the back, AKI, we saw that also how to prevent the AKI in the first place, but they're gonna be putting pressure on your units. Going back to the very, very important point you started with, which is getting the attention of the emergency response to the 1,000 patients. So I'll give you an example. Today, 1,000 patients on dialysis in Gaza, 1 million children need food. So what goes on that truck that goes in? So you need to make a lot of effort to point out that those patients are extremely vulnerable. So very, very important point of how you integrate within the country, but also within a response. I'll stop there. Thank you very much.
Yeah, thank you. Thank you, Professor Ali. Thank you. Your work with the ISN is very important in the world. Okay.
Thank you.
Yeah, thank you.
For next presentation, the next speaker is Yumi Jang from University of Ulsan. He is graduate at the Busan National University Department of Food and Nutrition, now assistant professor, Ulsan University Department of the Food Science and Nutrition. Now today, our speaker is Dietary from plan for Korea Renal Hemodialysis patient in a disaster emergency situation.
Okay, thank you for the nice introduction, and thank you for inviting me, and it is my big pleasure to be here. And my talk for today is about three things. It's like disaster, such as emergency situation, and hemodialysis patient, and the importance of diet. So we all know that a healthy diet is very important for everyone, and it is especially crucial for individuals with disease, and among them, the diet for patients with end-stage kidney disease, ESKD. ESKD in short is extremely important. ESKD patients undergo hemodialysis and must continuously manage their diet. In emergency situations such as disasters, when hemodialysis is delayed, these patients need to follow a specific dietary plan to maintain their health. So the Disaster Preparedness and Response Committee of KSN has created a dietary plan for ESKD patients in such emergency situations. So today I'd like to briefly introduce this plan. So over the past 10 years in Korea, the number of patients with end-stage kidney disease, ESKD, has increased, especially among people aged 50 and older, and particularly for people ages 70 and older, the number more than doubled. And for renal replacement therapy for these ESKD patients, the majority, about 79%, undergo hemodialysis treatment. So this shows a big increase over the last 10 years. And patients undergoing hemodialysis treatments stay in the hospitals like hemodialysis unit and receiving treatment 2 to 3 times a week, with each session lasting on average of over 4 hours. And in the event of natural disasters such as earthquake and typhoons or floods, and isolation can make it difficult to receive hemodialysis treatment, so leading to emergencies. So furthermore, social disasters like fire, power outages, or water shortages pose significant risks to hemodialysis treatment, which relies on societal infrastructure such as water and electricity. So therefore, it is crucial to prepare disaster response manual for hemodialysis unit to handle these challenging situations effectively. So extensive researches and studies on establishing disaster response system have been conducted by countries such as the United States and Japan and other advanced nations worldwide. In response to disasters, the United States Centers for Medicare and Medicaid Services, CMS, has developed and provided a booklet titled Preparing for Emergencies as a guideline for patients undergoing hemodialysis treatment. So the contents of this booklet serve as a helpful manual during emergency situation as outlined in the following table of contents. And furthermore, the Centers for Disease Control and Prevention, CDC, in the United States also provide detailed guidelines for hemodialysis patients to follow in emergency situations. One particularly important aspect to note is the 3-day emergency diet plan. So this plan outlines the dietary composition that ESKD patients who require regular hemodialysis treatment should adhere to in situations where dialysis treatment is delayed due to emergency circumstances. The important thing, as specified in this guideline, is that if you have to miss the treatment, follow the 3-day emergency diet. And this diet does not take the place of dialysis, but can help and save your life. So this is the 3-day meal plan provided by CDC of the United States. So there is 3 days meal plan, day 1, day 2, and day 3. And each day have breakfast, morning snack, lunch, afternoon snack, and dinner. So you can follow this dietary plan. So let us consider the disaster situation in Korea in this point. The 2017 Gyeongju Pohang earthquake led to instances where dialysis was interrupted. And additionally, the COVID-19 pandemic in 2020 caused delays in dialysis treatment for patients. Such disaster situations pose a significant risk to ESKD patients who rely on dialysis for survival. Therefore, Korea also needs to be prepared for disasters. However, proper response and education systems have not yet been established. As a result, we need to develop standardized response guidelines to prepare for unavoidable dialysis interruptions due to natural disasters as well as emerging infection disease disasters. So firstly, for emergency situation, using the 3-day meal plan developed in the United States, the CDC one, which we reviewed earlier, is impractical for realistic application in Korea due to the inclusion of many ingredients that are not commonly consumed domestically. So it is essential to develop a meal plan tailored specifically for Koreans. Therefore, the Disaster Preparedness and Response Committee of KSN has formulated dietary recommendations and 3-day meal plan for Korean ESKD patients in situations where hemodialysis may be delayed due to emergency circumstances. Okay, before we move on to the 3-day meal plan for Koreans, here are the principles of the meal plan. Basically, this diet is stricter than the regular renal diet. It has been designed to limit the amount of waste and fluid buildup in the body if the patients are unable to receive dialysis. If the hemodialysis cannot be performed, accumulation of dietary salt and fluid can lead to edema, and in severe cases, respiratory distress due to pulmonary edema may occur. Therefore, strict restriction of fluid and salt intake is crucial. And as you know, failure to excrete potassium can result in life-threatening arrhythmia due to hyperkalemia. Therefore, for the safety, potassium intake should be strictly limited. Okay, in addition to these dietary restrictions, adequate calorie intake is also essential. So inadequate energy intake may lead to muscle protein breakdown for energy, and then resulting in muscle loss and increased toxicity. And therefore, carbohydrate and fat should be actively utilized to provide sufficient calories. And lastly, while ensuring adequate high-quality protein intake, further restrict phosphorus intake. So based on this principle, a more stringent dietary regimen has been developed for a Korean-style digestive response 3-day meal plan, particularly designed for situations where adequate dialysis treatment is challenging. So 2 meal plans have been prepared to accommodate scenarios, like 2 scenarios where cooking at home is not feasible or possible due to disaster conditions. The first meal plan is for a massive and extreme disaster scenario where natural disasters like earthquake, typhoons, or flood may lead to societal emergencies such as fires or power outages, and making it impossible to use water and electricity. So therefore, we propose a 3-day meal plan for situations where food preparation and cooking are challenging due to water and electricity being cut off. So due to power outage restricting refrigerator use, we also consider food shelf life. Therefore, the meal plan includes canned food like canned fruit cocktail and canned pineapple and canned tuna and like canned low sodium salmon, and then sterilized milk like here, and also cereals for the breakfast. You can see 1 serving size of the cereal for breakfast, and easy to make sandwiches like tuna mayo sandwich, chicken sandwich, and salmon sandwich like that. So this plan assumes that necessary groceries can be purchased in advance considering this situation. However, as you can see, this meal plan is still impractical for Koreans. It closely resembles the diet recommended by the US CDC and differs significantly from the typical daily diet of Koreans, making it difficult to realistically follow. So moreover, prolonged power outage exceeding 3 days are rare in Korea, and situations like typhoons often provide advance warning through alert and alarms, allowing Koreans to prepare accordingly. So before looking at examples of the second meal plan, realistic follow is hard to realistic follow. So we have prepared the second meal plan tailored for Koreans in response to domestic disaster situation. So before we move on to the second meal plan, let's first examine the structure of traditional Korean meal. So you can see in the traditional Korean meal, here is the example of Korean meal babsang. In the traditional Korean meal, steamed rice like bap is served with soup, this guk. And additionally, the table babsang includes side dishes such as kimchi, namul, and various vegetables and high-protein dishes like banchan. And taking this traditional Korean dietary element into account, we have designed the second meal plan accordingly. So this is the second meal plan. So when you follow the second meal plan, you can have about 1,700 kilocalories per energy and some carbohydrate, protein, fat, and very low amount of potassium. And the first goal was to limit the potassium intake for safety. So high potassium food were excluded and low potassium food were mainly included. So potassium is widely distributed in many food and it is particularly abundant in vegetables and fruits. As you can see in the table, vegetables and fruits are categorized into low and moderate and high potassium based on their potassium contents. And by referring to this table, we can select low potassium food accordingly, like this section. Not only does food selection matter, but also how we prepare and cook this food can impact their potassium content. And since potassium is water soluble, and soaking vegetables in water and rinsing them before use can help remove a significant amount of potassium from the food. And boiling greens before cooking them can further reduce their potassium level from the food. And when it comes to grains, the refined grains that have lower potassium contents compared to unrefined ones. Therefore, it is recommended to choose white rice over mixed grains. That's why I included like white rice with the steamed rice instead of the grains. And additionally, it's advised to avoid nuts such as peanut and almond as they are high in potassium. And canned fruits contain less potassium compared to fresh fruit, and making them a better option for those needing to limit potassium intake. However, patients with diabetic ESKD should avoid the syrup in canned fruit because it can rapidly raise blood sugar level. Instead, they should only eat the fruit pieces after draining the syrup from the canned fruit. By making these adjustments in food selection and preparation, we can effectively manage our potassium intake and support better health outcomes in this situation. So let's return to the second diet plan again. And soup, like goop, was excluded to limit sodium and fluid intake from this diet plan. And furthermore, instead of high sodium kimchi, we can opt for low sodium kimchi, like here, kimchi low salt cabbages, and also use vinegar to enhance flavor, actively utilizing mild pickling method, like you can find this pickled radish. Additionally, considering many dialysis patients also have diabetes, I mentioned before, the diet was designed as a linear diabetic diet. Also, convenient foods were chosen for the special situation like digester, and aiming for sufficient and balanced nutrition. You can find this kimchi fried rice, bibimbap, and omelette rice, and bibimbap like that. And to accommodate modern dietary preference, lunch options were provided as either bread instead of rice, labeled as lunch B here, and you can choose either lunch A or B in this from this diet plan. So moreover, we propose to use this food exchange list to allow patients to easily plan a balanced diet that suits for their personal taste and ingredient availability while referencing the provided meal plan for guidance. So we recommend using the food exchange list for renal disease patients, which categorize the food with similar nutritional content into 7 food groups, like this grain group, and meat substitute group, vegetable, fat, meat, milk and dairy food, and fruit and caloric supplement group. As shown in this table, these groups are divided into 7 categories, and each food is expressed in terms of 1 exchange unit or serving. So an exchange unit represents the weight of food with similar nutrient contents. So one of the advantages is that within the same food group, the same category, food can be easily exchanged without complex calculations according to the designated exchanging unit. So for example, 1/3 cup of steamed rice, like here, and also 1 slice of bread here. Both of them are located in the same group, and these both correspond to the 1 exchange unit in the grain group and have similar nutrient contents, so we can exchange them. We easily exchange either one for your diet plan. And this is the way to make meal planning using the food exchange method in the beginning. So first, we need to determine the daily calorie requirement and the composition ratios of energy nutrient tailored to each individual, because individuals have different energy requirement. And then we'll establish the exchange unit for each food group, and starting with dairy, vegetables, and fruit. And taking into account the intake of carbohydrate, protein, fat, as well as potassium, sodium, and phosphorus levels. And we'll decide the exchange unit for remaining food groups. And next, we'll distribute this determined exchange unit across meals and snacks. By referring to the example of the food exchange list provided, we can select food from each food group to complete the diet plan. So therefore, based on the suggested meal plan, we have expressed the diet in exchange unit to allow patients to substitute their desired food using the food exchange list. So this table, you can see from this slide, is the meal plan for day 1, the first day. Using this as a reference, you can select different food within the same group according to the designated number of the unit. So we expressed here. So first day of the diet plan exchange unit is here with the different categories of food. So point to consider when you use the food exchange list, food can only be changed within the same food group. So for example, steamed rice, the 1/3 bowl and 1 slice of bread should be exchanged using the same exchange unit. So you cannot change the 1/3 bowl of steamed rice with 2 slices of the bread, and also not from the different groups of the food. So to summarize, in the emergency or natural disaster situation, ESKD patients can follow this emergency proposal and meal plan, 3-day meal plan, if they are unable to receive dialysis. And this proposal and meal plan are expected to serve as educational materials that can mitigate the impact of disaster on dialysis patients when followed in special situation like disaster. However, please note that this meal plan should be used in emergency situation only. And this diet cannot be a substitute for dialysis. So I hope that this proposal and meal plan will be helpful to dialysis patients in disaster situation. So finally, I want to thank the Disaster Preparedness and Response Committee members of KSN, and I'd especially like to extend my gratitude to the research group for the emergency meal plan for Korean people on hemodialysis listed here. So here is where I stop, and thank you very much. I'm happy to take any questions.
Brought in one question beside the difficult availability, there are any other disadvantages of the CDC recommended diet for Korean patients?
Yes, okay, CDC recommendation, like the 3-day meal plan from CDC, we actually refer to it very closely, but the first disadvantage is, like you said, the availability of the ingredients, because very different style of the diet. And second thing is that CDC diet did not consider about the diabetic patient because they included many jelly, jam, like caloric supplement to match the calorie requirement. But in our diet plan, we consider that patient too because more than 50% of more than 50% of the hemodialysis patients have the diabetes. So we consider that point. So that can be the second disadvantages when we follow this CDC diet plan. Thank you for the question.
Any question from?
Yeah, so could I just ask, have you tested out this plan yet?
Thank you for the question. And we just developed this diet plan, so we haven't applied to the patient yet.
So just a few comments for this diet plan. It's extremely luxurious to have. I would love to have meal. You based on your dietary plan, you are looking at a protein intake of about 0.8 grams per kilogram per day for 60 kilograms, and that's a diet plan is ideal, but you really need to test it. In an unplanned disaster, so this will be good for a planned disaster when you know the disaster is coming, that there is a hurricane on the way and you're preparing for it. But in an unplanned disaster, like for example Hurricane Katrina, it's estimated that we are able to reach a hemodialysis patient at an average of about 3 to 5 days. So, and the other way is that if you have a 0.8 grams per kilogram per day diet, protein diet, you are going to generate significant amount of urea because that's the normal protein requirements of a normal human being. And really, if the patients can't get access to hemodialysis, you want a lower urea generation, and you might want to push your protein requirements to much lower in a short period of time. And a lot of the dietary requirements of a normal human being may need to be scaled down in a disaster, especially in an unplanned situation. So, as I said, it's always ideal to create a plan. But once a disaster happens, especially for an unplanned disaster, and when you're not certain when your patients are going to get dialysis, the normal requirements of a human being really needs to come down to generate lower amount of phosphate and urea, so you can prolong the need that you actually need the dialysis. I don't even eat 5 meals a day. This is a really luxurious diet, so
Yeah.
I'll be happy to test out your results.
Yeah, thank
Very
you.
good point.
Thank you for Adrian comments, and I want to another explanation, and I'm colleague with her. There is so many discussion points in this emergency plan, and we also have discussed about the protein restriction between the balance using Korean food energy and what is the benefit between the sodium and fluid restriction between and versus the protein restriction. So, but the first proposed in this diet plan is to usable practice guideline for our patients. So we will discuss again, and we will endorse this guideline to the clinical nutrition and specialists, and we will discuss about the shortcoming this guideline. Thank you.
And I want to add some more information. As Dr. Yu mentioned before, so our committee discussed about this issue many times, and we know high amount of protein intake can cause the uremia, and also food with protein, high amount of protein also contain the phosphorus, and we know about the dangerous point of the intake high amount of protein and phosphorus. However, to reach the requirement of the energy per day, we didn't try to reduce the protein amount from the diet, and also it is less likely cause urgent complications compared to potassium and sodium. Like when we consider about the protein and phosphorus. And so for this diet, we put some relatively relaxable restriction on the protein and phosphorus. That's the point. Thank you.
Thank you, Professor. I think it's a matter of the severity or the definition of disaster. I think we did not assume the disaster that lasts longer than 4 or 5 days. We just think about like COVID situation, which patient cannot get dialysis for 1 or 2 days. We did not assume like Hurricane Katrina or the earthquake, big earthquake like Japan or Beirut. So I think that there was a little bit a difference between the doctor said and our situation. So if the situation get much worse, we cannot apply the second plan, of course.
Sure.
So yes, and that's a good point that we will think about it. Thank you.
Yes, so thank you, and that's why we prepared the 2 scenarios based diet plan. And in that case, we can definitely follow the first plan of the diet. Thank you. Any other questions?
Yeah, thank you. Good speech and answer. Thank you. Next speaker is Wookjin Choi from Ulsan University Hospital. He graduated Ulsan University College of Medicine 2005. Now professor of the Ulsan College University and Ulsan University Hospital. Next title is Emergency Medicine System for Disaster Response in Hospital.
Yeah, thank you. Thank you for introduction. In addition, previous speaker had said a general disaster situation. So I'd like to focus this time a bit more on in hospital disaster or instant situation. In the interest of time, I'm going to you quick and easy introduction rather than a lot of detail because of limited time. So my background is mass disaster casualty, but however, I think these things I'm going to talk about will be helpful for nephrologist or hemodialysis specialist. So yes. Good morning, everyone. My name is Dr. Wookjin Choi. I'm great honored to be here in this presentation today. I work at Emergency Department at University of Ulsan, Republic of Korea. Today I will be discussing important topic, the emergency medical system for disaster response in hospital. But focused on artificial kidney unit or dialysis unit or dialysis center. I'm looking forward to insight my strategies to can enhance your preparedness and response capability in the face of hospital several instances. I have no conflict to interest the CY, but however, I am the director of education for hospital instant command system education program at the KSDM. This slide sum up the key question: how should a hemodialysis unit respond to difficult or different disaster situation? We will have some situation, including fire or power shortage or and natural disasters such as flood. Yeah. My presentation consists of several parts. So first, I will discuss the hospital instance command system, and then the rest I will discuss and talk with you focused on hemodialysis unit aspect. So first, we have to understanding hospital instance system. Let's begin with understanding hospital instance command system. As abbreviation HICS, I will talk as this system to talk to you as HICS. HICS is a standardization approach to incident management tailored for hospital, such as a healthcare provider or organization. It includes key components, clear role and responsibility, and structured chain of command. Two photos show to us in action where the response is controlled from command center in specific location in your or our hospital, such as conference room or auditorium, and then on August 5th, 2022, some disaster has occurred. Fire broke out in commercial building in Korea. Most of the patients in this building were undergoing dialysis at that time, so making evacuation extremely difficult. So many casualties had occurred. This instance highlights the unique challenge faced by hemodialysis unit during emergency and disaster situation. The instance show how important it is to have a strong plan to us for dealing disaster. The hospital incident command system is designated to be flexible and adjustable to meet the specific needs and capability of hospital. You can step anywhere from 1 to 70 positions as you need, making a highly customizable. So HICS is a key component. Is, as you see, consists of EOP, emergency operating plan, and ensuring the efficient response. And HICS can integrated to interact with the community, such as federal, preparedness, and civil government, and so on. Including this, we can consider resource management and financial support. Let's talk about HVA, hazard vulnerability analysis in your hospital or in your city, in your regions. Hospital, as you, in terms of analysis, we can use Kaiser scoring tool. Such as scoring tool is you can score as the possibility of risk. So by analyzing this hazard, we can understand and the risk and prioritize our response plans. This help to ensure the hospital is prepared for variable of emergency situation, from natural disaster and to man-made disaster. We can suffer so many disasters, such as from natural disaster to man-made disaster. Here is an example of Kaiser tool to evaluate the risk of vulnerability. You can score various disasters based on the frequency and see where your organization is most valuable as you think. Yeah. But in this education program, according they provide several scenario. Scenario from 1 to 13. Bomb threat and fire hazard, mother sphere, internal flooding, loss of power, and so on. But it can use not only in institution, but also in your hemodialysis unit or center, where staff are working. There are example several insider threat scenario. Yeah. Step for implementing Higgs, when you consider this, you can imagine 4 important steps from activating the operations plan to deploy resource. So first, activate the operation plan. When a disaster occurred, this plan guide our emergency or hospital response procedure and responsibility. Next, set up. Next, set up instant command. Instant command as including commander or important steps providing or supporting commander. So instant commander, you can think, take a charge and assign a role to initiate and close this scenario and response to such as instant or disaster major events. And then create instant, we can develop and create the instant action plan. Action plan include also objective strategy and our resource to the tailored to the instance needs. And next step, communicate and coordinate between our hospitals, so many parts in your hospital or in your dialysis unit, and ensure clear and consistent communication plan. We can use standardized form and tool for these steps. Last, deployment resource according to the IAP, Instant Action Plan, included to allocate staff, equipment, and supply the necessary for this response. And overall, we can develop this step, and we can summarize this hospital instance command plan. Yeah, let's go over EOP first. EOP consists of 6 parts. So communication, as I mentioned, ensure effective communication. Channels are in place for internal and external resource and modality during emergency. And resource and asset is also important, must be considered. And safety and security for healthcare provider and patient also including. So step responsibility consists action plan when you meet instant or disaster situation. Utility include also power and water and so healthcare material to treat the patient. Clinical support activity means maintain continuity of clinical service such as hemodialysis and critical care for the patient. When we meet disrupted situation as you meet a disaster. Yep. But you saw previous slide typical EOP operation plan. but also can be provided in hemodialysis or dialysis units. The following example, EOP for dialysis center or hemodialysis unit. The following example consists of 4 parts. This material presented previously New York City Department of Health and Mental Hygiene in the United States. First, you must have emergency telephone number and address to call or communicate, talk with others as disaster situation, and then template annex for emergency response, fire or loss of power and lack of water system, and as I mentioned, as the vulnerability analysis tool, you can imagine in your country, in your hospital, in your regions, to determine the probability or risk to assist in planning. This facilitated storage and distribution of medical materials for patients. Let's take a look at the incident command system more detailedly. This is a picture to explain this. Incident command HIC system is organized like a tree, as you see. Some parts consist of so many organization. Each component, each component is color coded for each identification at a glance for you. So, example, white means command line. So hospital commander and they who support him, and administration part means green, and logistics is yellow, operation red, and planning blue. So as you see, that's so simple to at a glance. More detailedly, I will talk about this. Establish instant command ICP is a crucial step in hospital at initiates. ICP served as a central location and important part when where the instant command is the key step manager to emergency response. It ensures as you see, coordinate communication, operation, planning, logistics, and including financial support. Set up the ICP. ICP is very important and essential for efficient and response emergency management. So, who are you? Who is him? At this floor. Thank you. In a typical system, if there is an install command, as I mentioned, like this, that help control and design to respond to, and decide to start the response at disaster situation. But as general situation, in hemodialysis unit, there are no probably have to. I think maybe as instant commander have to be filled by dialysis specialist as him. So let's take a look communication plan. Broadly speaking, it include internal communication system and external communication system between hospital and other government or fire station and policemen and so on. So in the HIC system, in terms of internal communication strategies, use a color code. As you know, so do you know code blue, code red, and like that? In his system, means red means immediate action required step, like a fire situation, as you see. And orange is means caution, potential issue, but not too emergency compared to red, as you see. So using this color code system, all steps quickly and understand that the situation and respond appropriately to any several instances. So I think this color code system ensures everyone on the same page, same signal during an emergency situation. So that is very convenient system. So and in general, some hospital use this code actually, code blue, code red, code green, and so on. But however, in HIC system can be used this as this disaster response. Look at external coordination, communication. External communication involves close contact always with response to disaster, government officials and police station, relative organization during a disaster. But communication system must be gradually developed through repeatedly experienced situation and training exercise. Yeah, that is training and exercise. I'd like to deal with this. Training on disaster response is crucial. Why? Comprehensive knowledge is at first time not perfect, but we have to more do things to promote and wider result. So take a look at this. Briefly differentiate between type exercise according to so many educators, so many professors. Tabletop exercise is very easy and easy to do for response of disaster. Informal discussion consists of this, and then we can do drill, some drill. Drill have a supervised activity, testing or specific according tabletop exercise, and then we can make a wider functional exercise and the rest full scale exercise FTX. We can do multi-agents exercise, functional and real-time response. Yeah. So let's take a look at something to consider. In dialysis, you need to essential to have following supplies and equipment, essential medical supplies, consumables, up to equipment like this. But most important is backup system, like APC or UPS system, for behalf of backup power, water of supply system, and communication plan, yeah, like this. So I skip. I'd like to point this. When you meet a disaster or an incident situation, we can do anyone do as evacuation process for patient. So detailed emergency disconnect procedure in dialysis unit or center, clear evacuation process is crucial for patient safety during emergencies. Patients may need assistance to evacuation safely, as this. So, yeah, skip this. During response disaster, we can provide must be important to for patients' families. So after emergency, it is crucial to also return to normal operation, normal situation, assess and address the impact to ensure smooth and transition. We can discuss the other authority. Yep. Managing emergency response to this crisis consumed so many financial resources for proper plan already prepared for this. We can discuss case study and lessons learned. So many earthquakes after this, we will lost dialysis unit. But according so many material, after 1 week, recovered up to 80%, as you are aware. But we can prepare during that period some plan to treat the patient at that time. So I have to point to this as a special tool as per the fire safety requirement. So at least one time per year we can consider and prepare about this. But unfortunately, this is a Korean Society Nephrology committee disaster response regulation for dialysis unit. As you see, one page is a flood situation. The other page is power shortage. At that, I think in order to respond to disaster efficiently, the volume is somewhat more limited. We can do properly respond to disaster. So, yep, time's up. Thank you for your attention. Do you have any question to discuss freely? Thank you.
Thank you for good speech. Have you any question in the floor?
Thank you for the good the lecture. I'm Hei Park from Konyang Sacred Heart Hospital. I have one question. So, do you think in Korean situation, you told us that the training and the exercise is important in ahead of the disaster preparedness? What do you think about the frequency of the training, like tabletop exercise and drills and all those things?
Yeah, that is a good question. But it is also difficult to talk and discuss with you. But so many specialists recommend the frequency of training in terms of that at least one time per year, at least. But I know usually most dialysis center and hemodialysis unit did not train, did not do anything during 1 year. So I recommend at least tabletop exercise, and then we can do further exercise, and then after that. Thank you.
Yeah, thank you, Professor.
Last one.
Yes. Oh, please. Thank you, Professor Choi. Thank you for your nice lecture. And I understand and I agree with your comment about the Korean disaster guideline. And our society and our community are now ongoing to upgrade our disaster response guideline. So I want to ask, and I want to the Korean Society of Disaster Medicine, please, I want to ask that please make some kind of YouTube clip or the training module with not only document and the real practice YouTube clip. So because so many needs in our society in the local dialysis clinic, what is the standard training module in the dialysis facility to train? So I heard about the HIC system. That is a very good documented practice rule. So I want to ask and that we together make some standardized training module for the easy and replicable training module. Please consider it.
Yeah, thank you your comment. I think it is principle and structure are also crucial for small dialysis center and dialysis unit within commercial building. So that is there are several reasons, clearer definition, organizational response, and effective resource management defined, and communication network skill between other organizations. So including this, help that unit to apply with the HIX system. Yeah.
The next question.
Yuri from Renal University. It's not just about its patient point of view. It's just because it's about the CRE positive HD patient. Because private unit refuse to receive this CRE positive patient, so you cannot send to the or return to the private center. What's the recommendation for this CRE positive patient?
Yeah, I think that is not a question for me. You can answer about that.
Yeah, with the many kinds of the training program in disaster situation. Today, this stage, we have two hospital HIX program. And one is the Chungnam, and the other is in Seoul in middle-sized hospital. If you can see, do you want to see? And we invite you.
But CRA problem is very difficult to deal with. But we can discuss as an emergency department and the progress.
Time is up. Yeah.
Time is over. Thank you for good speech.